Thank you, David. I could have been shorter, but it's okay. I wasn't too bad, too painful. I guess as the person that has the name in the meeting, I had the privilege to present my experience without data. This is July now will be 50 years that I've been working in cardiac surgery. 3 years as a trainee and 47 as an independent practitioner. Form follows function is an expression by an architect from Chicago about over 100 years ago in putting high rises. As society changed, he convinced all his students and workers that the construction of a building should fulfill its need, the function of the building. What the building is for, a library, a hotel, or a conference room. In few parts of the body, musculoskeletal system is one where form follows function. My hand is the way it is, likely because of adaptation over the millions of years that monkey turned into a human. The mitral valve is another one. It's a fascinating structure. And particularly young surgeons, unless you spend some time with hearts and take a look at the intricacies of the mitral valve, the anatomy, is largely supported by muscle, in the inflow and the outflow. Only the part underneath the aortic valve is connective tissue. The rest is all muscle. So it's a fibroelastic structure inside of muscle. As such, every component around the mitral valve affects its function. Every component, the form, the anatomy affect the function. The left atrium, the mitral annulus, the leaflet, chorda tendineae, and so on and on. They're all important parts for the function of the mitral valve. I mentioned already briefly to you during questioning Dr. Cox on atrial myopathy. The left atrium gets sick, particularly as you get older. Primary myopathy of the left atrium causes atrial fibrillation in the elderly patient. But much more than that, it can cause mitral regurgitation. It can cause mitral valve dysfunction. Patients that have hypertension, patients that have atrial fibrillation for a very long time, they develop mitral regurgitation. So this concept that small annuloplasty ring cures mitral regurgitation has to be revisited in looking at your patients. If your patients had atrial myopathy, of course, a small ring is going to cure the problem because you reduce the whole thing and the mismatch caused by enlarged atrium is corrected by a surgeon. That's why the clip won't work very well. And there are reports already in functional atrial mitral regurgitation. Putting a clip is a palliation that doesn't last very long because it does not address the problem of the sliding of the leaflet towards the left atrium. Mitral annulus is a misnomer. Anatomists, mostly from India, look at some 200 normal human hearts, young people, 18 to 20 or 30. 85% of us do not have a mitral annulus. We all have an intervallar fibrous body. We all have a lateral and a medial fibrous trigon and a very strong fibrous skeleton in between those trigons. But very little goes to the tricuspid valve, almost none to the aortic valve, and very little to the posterior leaflet. It disappears after the first centimeter or so. So 80% of us don't have mitral annulus. Well, but 30% of us have a gene that causes myxomas degeneration of the mitral valve. And that gene expresses itself differently in different human beings. So it's not unexpected that if you don't have mitral annulus, you don't have a fibrous structure, and you have degeneration of the mitral leaflets, you're going to have disjunction. When I first learned about this, in the days I used to read the New England Journal of Medicine, because when I was young, you read every journal. And it was easy to follow all the literature back in the 80s. Now it's impossible. So many publications. But I took this to heart. I was doing already sliding plasty. I was resecting P2 in those days, 1987. Then I discovered that frequently the P2 was not in the ventricle, was a centimeter away from the ventricle. So we changed. We created an operative technique. I'm going to detach not only 2 or 3 centimeters, I'm going to detach the whole posterior leaflet and move the posterior leaflet inside the ventricle. See if it is correct mitral annulus disjunction and mitral regurgitation. And we published this. Almost invariably, if you're going to operate on a patient who had advanced, is it dark enough? Can you darken the room a bit more? I don't need the light in my face either. They all know how I look like. Patients with advanced myxoma degeneration almost invariably have mitral annulus disjunction. And instead to repair only what is prolapsing, the so-called preserve, it doesn't work in this kind of disease. I don't think it works. At least it doesn't work for very long. I think the treatment is you detach the whole posterior leaflet. You detach the whole posterior leaflet from commissure to commissure. It doesn't really take very long. It's only about 8, 9 centimeters long. And then when you do an annuloplasty, you don't put the annuloplasty stitch in the atrialized, displaced annulus. Put the first suture in the medial fibrous trigon. If we could darken a bit more, you can see this. This is a very old movie, by the way, 1999. You're going to see the date in the echo. And then look at the annuloplasty where it goes. It goes through the endocardium of the left ventricle and approximate everything. You correct the form follow function. You correct the abnormality in anatomy. Every time you resect and move posterior leaflet, I believe you should resect all the secondary chorda tendina. There's an excessive amount of leaflet, do your resection. Not only in the length, but the height. And here we are resecting part of P2, make a bit shorter than was before. Another idiosyncrasy, I believe they should put no knots in the atrial side of the mitral valve. Every knot should be imbricate. In other words, put in the ventricular side of the repair. And then once this is done, you reattach the leaflet not to the annulus, but to the endocardium of the left ventricle, like we are doing now. So the leaflet is being resutured where the mitral annulus was supposed to be. And you're hoping that by changes anatomy, you're going to be creating a new annulus for this very degenerated mitral valve leaflet. Then, of course, you didn't do a thing for the prolapse yet. And I started in 85, and we progressed to this here. We have a bunch of Gore-Tex, and this is done. We do believe in multiple loops. You make sequential loops. You tie the Gore-Tex to the papillary muscle, and then pass twice through the free margin of the leaflet, go back, pass once only to the fibrous portion of the papillary muscle, back on the leaflet, and a single Gore-Tex can create 2, 4, up to 6 interdependent coordinate tendina. This is by far more forgiving as far as adjusted length is concerned. Beginners should always start putting the Gore-Tex where a normal chorda is, and then progress towards the prolapsing segment of the leaflet. And then, of course, as has been shown by many, including ourselves, this disease requires annuloplasty. Unless you can stabilize the annulus with something that doesn't change in length anymore. I start with Carpentier ring because that's who I train with. But over the years, we learned that in this disease, all you need is a piece of Dacron in the posterior wall to hold things together like a bend, a flexible bend. Make your own if you like. And the mitral valve is repaired. This is correctional mitral annulus disjunction. Well, recently in the past decade, more and more papers appear in the mitral annulus disjunction is a predictor of sudden death in mitral regurgitation. Actually, the term malignant mitral valve prolapse now became prevalent in our clinical rounds. What's a malignant mitral valve prolapse? It's a bileaflet prolapse. The female gender, usually only second, third decades of life, who complain frequently of PVCs, and if you do a Holter, the PVCs are pretty malignant. And also, almost invariably, they have MAD. They have mitral annulus disjunction. Well, in this paper, and there's another one coming up later this year now, at 30 years, this one is at 25, we have added 5 more years, a mean follow-up of 19 years in our 3,000 mitral valves. Out of 135 patients that die after I have repaired the mitral valve, 25 die suddenly. We analyze those sudden deaths, and guess what? Bileaflet prolapse and MAD were protective. In other words, maybe the natural history of mitral valve prolapse, bileaflet prolapse, MAD in PVCs cause sudden death in young women. But if you repair the mitral valve, if you repair the MAD, in our hands, has done the opposite. 5 times less likely to die suddenly than the old guy who has a poor ventricle, the old woman has a poor ventricle. Dave Adams is going to talk more about this, and I'm going to leave it at that. We, in the past 5 years, we have had an ablation at the basic papillary muscle if we don't know the origin of the PVCs. The results are conflicting, but we are trying to find an answer to this problem of young women, particularly dying suddenly, and have MAD. Another problem that I tackled very early in my career is mitral annulus calcification. Mitral annulus calcification is a problem because you don't have a good therapy for that. I might sound crazy to you, lunatic, but I think if you have a calcium in the mitral valve, it is dysfunctional. So again, the axiom, form follows function. The only way to treat this effectively is by removing the calcium bar and do whatever you can for the mitral valve. This calcium bar is very simple to repair. The calcium bar that occurs in Barlow's. It's almost displaced from the ventricle. In the operate room, you always start by improving the exposure to the mitral valve by putting the annuloplasty stitch first. Well, there's a block of calcium there. I cannot do that in a calcium. So you skip that area. And then you start every operation that I do, mitral valve surgery with a calcium bar, I start the operation thinking I'm going to save this valve, not replace. So you take a sharp knife and free up the leaflet from the calcium bar. Leave as much leaflet as possible, but that's the only part that is going to make the mitral valve competent in the end. And then remove the calcium bar. I believe the best way is not ultrasonic debridement, it's sharp knife. Keep the knife between the calcium and the muscle, and you can fillet the whole thing out. Then, of course, in compact muscle, in other words, the muscle in the base of the ventricle, you do not need a patch. You can put a bunch of simple sutures, and then reattach the leaflet the way we did for the Barlow's. In other words, to the endocardium of the left ventricle. So you start to reattach the leaflet. Here's the normal annulus, reattach the leaf to the normal annulus. And then move on to like in the Barlow's before. The stitch go in the muscle, not in the atrialized annulus. There's no annulus. That's a remnant of the leaflet, piece of the leaflet that we left behind. And then, of course, once the posterior leaflet is reattach, you have to correct the prolapse. So it's a bit more complicated operation. And start with the posterior, and if you use a Gore-Tex the way I described, in multiple loops, it doesn't take that long, really. You can repair like a centimeter and a half of prolapse with a single Gore-Tex by passing 2 or 3 times. And then, of course, as I mentioned before, you do need a band, and you need an equine operate room, and it works very well. Look at the date of this, 2011. This is not a new video. We have been doing this for 30 years. Well, is he always this rosy? Can I always repair every mitral valve with MAC? Of course not. As a matter of fact, I'm a bit embarrassed to say, one of our residents is publishing a paper on this in Sugar experience. I have done just over 300 MAC. I've repaired only 90. 210, we've replaced the valve. In other words, like I didn't have enough leaflet to be able to repair. So extensive MAC, more often than not, at least in my hands, is replacement rather than repair. Shaving it the same way, you take the block of calcium. Unfortunately, this calcium involved the anterior leaflet, involved the medial fibrous trigon, and I don't believe in patching leaflets anymore. I try pericardium, I try bovine pericardium, equine pericardium, I try core matrix, they all fail. If you follow long enough, fails. So unless endocarditis is a small piece of autologous pericardium, we take bovine pericardium and reconstruct the annulus with bovine pericardium. Bovine pericardium is a problem because it calcifies. 10, 15 years, a block of calcium again, but as long as the valve doesn't become detached, that's okay. But we have now patients that come for the second time. In other words, you do this operation, you see here, recreating a new annulus with a bovine pericardium, and then 15 years later, the valve fails. You go inside hoping to be a simple mitral valve replacement, and it's the whole thing again. But it can be done. It's not the end of the... And the secret, and I keep repeating this, is you don't pass 10, 15 bites and pull the proline like you are doing for a hernia. No. Every loop has to be pulled individually, make it snug. Otherwise, you're going to have no myocardium left, particularly if your suture line involves the trabeculated muscle. The compact muscle is very forgiving for patching. Trabeculated is a nightmare. To be quite honest, sometimes I go through and put up a felt or a bovine pericardium epicardium if a trabeculated area needs stitching. Trabeculated area is a nivel for patch. In necrosis, 5, 6 days later, they develop patch dehiscence. This might be an idiosyncrasy, but in my very first paper in my career, I believe in papillary muscle annular continuity. So you resuspend the papillary muscle with a 4-0 Gore-Tex, pass 2 or 3 times, and bring the papillary muscle to the reconstructed mitral annulus, and then tie to the sewing ring of the valve as you finish the operation. Keep looking inside the ventricle, making sure the papillary muscles are taut, not excessively tight. I'm running out of time. I want to say a word about this here. We have not made much progress in post-inflammatory. Gebrinho is going to be talking to you later today about endocarditis, and I agree with most things Gebrinho is going to say. You should try to save the mitral valve whenever possible, as long as it doesn't require excessive amount of foreign material, patching of the leaflets. The myxomatous is the best pathology we have. Unfortunately, it's a very heterogeneous disease. The older person has the pathology that Dave Adams described as fibroelastic deficiency. There is no such a beast. No pathology ever described this. Fibroelastic deficiency, it means the level is low. Level of what? Of fibroelastic. Well, pathologists don't count how many fibroelastics in a leaflet. However, we know when you see one. Carpentier introduced this term, we all use it. 99% of the patients are either the second, the third, and the right on this side. Unfortunately, younger the patient, more they come to this side, more complicated pathology. And the myxomatous, I'm going to show to you later this year, if you follow for 20, 30 years, a number of them, the valve calcifies. Finally, I think after 30 or 40 years trying to repair functional MR, functional ventricular MR, I think we finally learned the whole thing is the tethering of the valve. You need a good transesophageal echo prior to the operation. The patient is young, and you think the patient is going to live more than 10, 20 years, and measure everything. In my hands, if the tethering is more than 10 millimeter in systole, if the anterior leaflet is less than 25 millimeter in length, and the angle between the posterior and the ventricular wall is less than 45 degrees, don't bother. In my hands, it's 100% recurrent MR. If the numbers are different, in other words, 8 millimeter tethering, 30 millimeter anterior leaflet is 90% or higher of success of operation when you do severance of the secondary chorda tendina in the affected area. If it's ischemic, the medial half, and reducing annuloplasty. Thank you for your attention. Thank you for coming here.